Off very shortly. We're just allowing you all to enter. Usually we start about 3 minutes after the designated meeting start time to allow people transitioning. Thanks so much for joining us again. We had our August holiday and we're back in the swing of things with our September meeting and looking forward to the meeting today. Again, we'll start very shortly, and it took 2 to 3 minutes just to allow people to transition. It's nice to see so many friends on the call. Demry, our amazing master of ceremonies, is giving the details, but as you come in, if you wouldn't mind typing your name and organization in the chat so we can have a record and so entities on the call can know where you hail from. I am Sarah DeSilvia, the Director of Terminology for Gravity Project, and I'm joined, Tracy, do you want to introduce yourself? I'm joined by our amazing member and friend, Tracy Wayne.
Yeah,
Tracy?
absolutely. Thank you for inviting me. My name is Tracy Wang. I am a Digital Solutions Director at Elevance Health. Been with the company for about 18 years, have a public health background, and I'm currently responsible for the delivery of whole health analytics and data. And I also sit on the Gravity Project Operating Committee, where Sarah and the great Vanessa coordinate. So pleased to be here.
We are so excited to have you here as well.
Mhm.
And I see friends, Sarah Downer on the call, all kinds of friends. Welcome. So I think for the sake of timeliness, we do have a fair bit of content to review today. We are going to go into our content directly. Again, keep on putting in your name and the organization you hail from into the chat as we go forward. As a standard development initiative, as part of the part of HL7, we are bound to antitrust practices in our work. And so whenever we start our work, we do try to make sure that this is very clear. So anybody participating in Gravity Project and in our public gatherings, we have the responsibility to comply fully with federal and state antitrust laws. We do ground on these concepts with every single public gathering. I'll do this in an hour or 2 hours on the Gravity Project terminology call as well. So just as a note, we try to be really gentle and thoughtful in our allocation of these. So adherence to the guidelines involves not only direct avoidance of any antitrust violations, but also avoidance of behavior that might be so construed. So just again, trying to think of the consensus-based open space that we're creating today. Next slide. I see friends from New York. Great. So quick little highlight. What is Gravity Project? We are a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. For the sake of, this is a revision of a presentation I gave earlier. For the sake of this collective, because this is a Gravity Implementation Affinity Group, our overview of Gravity is going to be a little bit shorter than usual. Next slide. We're incredibly grateful for our sponsors and members, of which Elevance Health is one. Thank you, Tracy. So we have both a like a sponsoring support model on our membership model, but also a designated membership model. This is unique within Gravity because in order to represent the complexity of social care voices and social care expertise, we have had to create designated partnerships with critical voices across the patient and social care ecosystem. So very grateful for our memberships, our members and sponsors, and the intentional governance community that helps us guide strategy and also prioritization within the Gravity work. And then thanks for joining. This Zoom meeting is being recorded, and recordings will be available on the Affinity Group Confluence page. Something of note, especially regarding the recording, and Demry already indicated that this particular topic is a response to like a request for this particular topic. So what we're trying to do at Gravity as well is create materials that can be referenced for specific questions. The specific question we heard was, how do I get started with implementing Gravity terminology and the complexity of all the value sets for all the things, right? Where do I start? So we are going to be recording it not only within the Affinity meeting, calendar, but also in our resources for implementation section. We have a webinar and recording section that focus on critical topics, kind of a library of sorts. So this will actually go in that place as well for future reference on this topic of tips and tricks for terminology. We ask that you mute yourself when you're not actively speaking and use your raise hand function to chime in with questions or comments. Both Tracy and I'm sure, are really open to questions. So raise your hand and don't worry about asking questions on the slides of reference. Next slide. Oh, and then one more thing, please do send any comments to everybody so that everyone can see the commentary. And then just as a note, if it's not sent to everybody, it's supposed to be sent just to me, I'm likely to read it out loud because in the scope of facilitating the meeting, it's hard for me to differentiate. So chat messages sent to everyone are best practices within our public meetings. So the agenda is as follows, just brief welcome, some announcements of the next slides, and then this terminology tips and tricks. Again, a revision of a presentation I gave at the CMS Connect-a-thon earlier on this summer. And then we really are trying to highlight grassroots implementer voices, right? We're at the point now where all of you are trying to apply the products and deliverables we create at Gravity in your real world settings. And we're trying to elevate voices that can speak to that. And I'm grateful that our friend and member, Tracy Wang from Elevance Health, is going to be speaking directly on applying Gravity terminology within her system. Then we'll have our open discussion and hopefully have enough time to answer any questions and then go into a wrap up and next steps. Any questions on the agenda? Seems like not. Okay, so I'm going to just start with a Gravity terminology orientation. This is again intended to be kind of a 101, right? So if I was an entity and trying to figure out how to implement Gravity terminologies because of any of the many drivers, where would I start? And then we'll segue into Tracy's presentation. Next slide. I wanted to lay out the objectives. Again, these are similar to the objectives we had at the CMS Connect-a-thon. Again, this is intended to be a learning piece of a learning deliverable that you can reference at any point in time. So we hope that you walk out of here having learned about Gravity Project terminology, our curation process and aligned activities, like how we do what we do. We want you to understand how Gravity data standards are curated in VSAC value sets for implementation uses and uses beyond like pretty much any use case you can imagine: population health, clinical practice, clinical decision-making, quality measures. We want you to gain insight into current regulations and policies that point to Gravity data standards. And you can see this in Tracy's presentation, right? So why is this timely now? It's because there are so many regulations and drivers pointing to Gravity standards. And so it is meant to be, standards are to create the common language. And luckily, most of the regulations incoming point to the common standard of Gravity terminologies. So we want you to understand that lay of the land. And then we're going to close with tips and tricks for how to distill all of the complexity and subtlety within Gravity value sets to whatever in line with those drivers to your particular setting in order to get going. Again, those are hopefully the 4 objectives that can be met, and you'll see them applied directly in Tracy's presentation to follow. Next slide. This is, again, a brief Gravity overview because we have many different materials on the Confluence that can help you in understanding our global picture. Gravity has 3 primary work streams. One of the work streams is the terminology division that I have the honor of leading. Our terminology public call is just at 4 o'clock Eastern Standard Time. So that is the language making division, right? So our job in that work stream is to identify terminology to support specific use cases such as screening, assess like diagnoses, goal setting, and intervention, but even leaning into additional use cases such as reimbursement or classification, as you'll see in the call later on today. We communicate with our other work stream, which is the technical work stream, which is our social determinants of health clinical care IG, through encoded value sets. So we create these packets of information. We'll talk a little bit about that in incoming slides that are then able to be referenced in the exchange standard, which is again that HL7 FHIR SDOH clinical care implementation guide available on the Confluence. That implementation guide is going through a couple different versions. We're working on new updates right now, but again, we communicate through terminology and those value sets in the middle. And then there's this work stream, which is where we test and evaluate and learn from implementers about how to enhance and improve our standards to meet your needs. So those 3 work streams, terminology, tech, and the implementation work stream, are the core of the work streams of Gravity. Next slide. The gravity terminology curation process is really formal. We're just going to briefly touch base on it. We definitely talk about it and apply it in our terminology workstream meetings. The reason why it's important here is if there is a reason why regulations and quality measures point to gravity value sets, it's because of this process, right? So when we started gravity, there was a very significant terminology gap. You couldn't name food insecurity, you couldn't name transportation insecurity, nor its subtypes. Most of the critical instruments to identify social risks were not built in, and certainly almost all of the core federal programs to address social needs were not in standard terminology. So there was a large gap to fill. And because there was a gap to fill, we had to create an evidence-based, consensus-driven process that basically served as an ongoing technical expert panel. And so sometimes quality measures and regulations have to convene technical expert panels to drive, evidence-based value sets. Gravity does that by design, right? So by doing that in this public consensus process, regulations and guidance can point to gravity because we're doing that evidence-based consensus work, by design in every single meeting that we have. So we have our public process, and then we go into a gap analysis, and then we work directly with the standard organizations to fill gaps. Like just a couple weeks ago, presenting at the IC10 Coordination and Maintenance Committee, working weekly with SNOMED US and International, and on our ongoing relationship with LOINC, right? And so this is all underwrites what we do, and exploring HCPCS, both level 1 and level 2, in our enhancement work that I'll be talking about more at 4 o'clock, right? So this is the process. It underwrites all of our terms and value sets and the evidentiary base and the consensus process, and the ethics that underwrite it are part of why our value sets are able to be pointed to by different regulations and entities. Next slide. We have, again, a few core, like 4 use cases that started our work. We've addressed every single one of the social determinants of health domains you see on the right side, just finishing our utility and security work in spring 2024. Our core base process, which is kind of the rinse and repeat, gathering experts, running the terminology public calls around 4 core activities of screening, assessment, and diagnoses, goal setting, interventions and treatment. And then we have this italics, right? Because those are our 4 base use cases. In order to fully address the needs of social needs and social risks and protective factors and the gamut of social care, we also are leaning into different use cases and activities beyond those 4. But those are the 4 base ones that you see in our VSAC value sets at this time. And then, of course, we test and validate them. Again, use cases, anything you can imagine, you'll hear that in Tracy's presentation. Patient care, care coordination, public health, population health, value-based payment, and clinical research. All of these terms that we're building are able, and supporting in value sets, are able to be leveraged for all of those different purposes. Next slide. This is an example of the terminology we built. Again, thinking of those initial 4 use cases, knowing that gravity is leaning into additional use cases. We have our standardized screening and assessment instruments. This is exemplified by one of the concepts from the Hunger Vital Sign or the USDA Gold Standard Food Security Module encoded in LOINC. And then you have our diagnostic terms, which are represented in green with food insecurity diagnoses in both SNOMED CT and IC10-CM. And then you have goal statements that can be used for shared care plannings across different settings. In my work in Vermont, we use electronic shared care plans on a daily basis, and this terminology is already part of how we share with clinical and social care entities on shared patients. And then you can see all of the interventions, right? So all of the core programs, and again, food insecurity is the example here. So your WIC program, any provision concepts, any critical professions, and any HCPCS codes that might be involved in reimbursement. We fill gaps, analyze programs, ensure every program is in there, and then create these sets of information. Next slide. And I created this just because, like, how does this relate to value sets? So there's all those specifics, and then we group them, right? So when you're going into VSAC and pulling down the value sets, you're pulling down a evidence-based, subject matter vetted set of instruments that are able to be used for food insecurity, an evidence-based set of diagnoses that are able to be used for diagnostic concepts, an evidence-based set of goals, and evidence-based set of interventions, right? So all of these are then curated in these sets of information called value sets that you can use. So not just one code, not just one instrument, not just one intervention, but all of them. Next slide. here are the value sets, and here are some ways to access them. So we, again, curate all this information on our Confluence in a section called Resources for Implementation. We have in our resources library a kind of primer on the resources for implementation on gravity value sets that you can find on the Confluence. So I'm not going to go too much into that structure there because that was an earlier call in 2024. But we steward over 240 value sets in the National Library of Medicine Value Set Authority Center, again, focused on those 4 core activities, which there are more incoming, both general value sets for every single social determinants of health domain we've addressed, and then more specific ones for every single domain, such as food insecurity or housing instability. Those value sets are what's pointed to by regulation. If you're doing selecting an instrument aligned with CMS annual wellness visit social risk assessment, look here, right? If you're trying to pick your instrument for SDOH risk assessment concepts with that new HCPCS code, look here, right? If you want to figure out qualifying interventions across the NCQA measure for a given domain, look here, right? So those gravity value sets are those collected, evidence-based, consensus-driven sets of information that regulations then reference. All of these value sets are hyperlinked from our Confluence on the gravity terminology value sets page, again, in resources for implementation. Next slide. Again, quick primer on regulation, more incoming. I was honored to participate in a paper on the quality measure ecosystem that was published in Health Affairs. This is the table that I adapted from that paper. It shows how each of the different existing quality measures and regulations align with gravity, both current alignment and future alignment. You can see there are a lot of gravity icons. Right. So there is a lot of information in the ecosystem on those different regulatory and quality measure requirements. Again, Tracy's going to be talking more about them a bit. But you can see the NCQA SNS measure. You can see guidance for IQR and MIPS coming down the pike shortly. You can see guidance for instruments with CMS special needs plans. So there's a lot of current and emerging focus on gravity value sets as the value sets and information of reference for each of these different programs in the ecosystem. Next slide. All right, so that was the learning objective 1. How do we do what we do? Learning objective 2. What are the drivers of the whys, right? We talked about NCQA, SNS. We talked about CMS instrument requirements, right? So hopefully we've addressed that. And I'm quickly going to go into tips and tricks and then pass the mic to my friend Tracy to go into how she's applying it in her ecosystem. All right, next slide. And this is directly in reference, all of these slides you're going to see are directly in reference with talking to implementers, trying to figure out what you all are doing, and trying to abstract some of that information on our slides in order to support the ecosystem. The next slides offer a few tips on implementing gravity-aligned data standards with considerations for national regulations in mind. There's not any current regulation besides USCDI that references our goals value sets, so I'm really leaning in specifically into this instruments, diagnostic concepts, and interventions, because these are the most common concepts you see referenced in regulation. So not ignoring goals, mind you, but specifically because implementers, because of those drivers, are responding to these 3. I wanted to highlight these 3 in the presentation. Next slide. All right, this is the instruments and screening the instruments and assessment instrument standards and LOINC tips to implementing. Next slide. And for those of you who've attended past Affinity calls, there's themes for things we've discussed prior, but again, not going too far into specific instances, but I will highlight them if we've covered it in a different call. So the most importantly, if you're trying to align with gravity terminology in line with the regulatory guidance, and it's already aligned, such as an example of this is the AHC Accountable Health Communities Health-Related Social Needs Screening Tool. The simplest thing to do is simply encode it, right? So if it's there, it's a comprehend for instrument, it's an instrument of reference, encoding it is the best path forward. If you're not, and you're trying to think about how to go forward, what we've heard very clearly and what we know from the ecosystem is it's really best to think by domain, right? And we think about this because we work very closely with entities trying to meet NCQA health equity plus certification, right, with their instruments. We get a lot of questions because if you're the standard of reference, you get all kinds of questions of whether or not my instrument applies, right? And I believe Tracy might be talking a little bit about this in the future in her presentation as well. But if you're not using like a comprehensive instrument that's referenced specifically in standards, if you think by domain, you avoid some of the complexity because most instruments are actually collations of standard instruments that they just bring into a comprehensive instrument and rename. So if you think by domain, and these are the domains of reference, again, in current regulation, you have food insecurity, housing instability, homelessness, inadequate housing, transportation insecurity, utility insecurity, interpersonal safety, and social isolation. I elevate social isolation because it's a core, federally approached domain of reference that we have really solid standards to support, and they are definitely our entities that are highlighting this in their work. I have interpersonal safety in parentheses because if you look to the pings from CMS on revising the current SDOH IQR measure, SDOH 1 and 2, there is a move to take interpersonal safety out and address it in a specific domain. So that's why it's in parentheses. If you look at the pings from the ecosystem, that's what's coming down the pike. So most comprehensive multi-domain instruments just repeat the same domain level questions as I mentioned. So start here. So if most comprehensive instruments are using the Hunger Vital Sign, which is a tool developed by our friends at Children's Health Watch, that is a very good place to start. Most comprehensive instruments also borrow the same component of the Accountable Health Communities Health-Related Social Needs Screening tool from a tool called the Norwalk tool to do inadequate housing. And most comprehensive instruments also encode utilize utility insecurity questions from Children's Health Watch. Right, so it can be hard to boil the ocean and figure out where to start, but if you simply reference gravity and code like guidance on LOINC encoded screening instruments and pick one of the instruments that's already there by domain, you are off to the races because each of those concepts has LOINC codes to support your work, and each of those concepts are repeated across most other comprehensive instruments in the ecosystem. Next slide. We do have, all kinds of materials on gravity regarding every single instrument we've ever assessed. If you want to review every single instrument accepted for a given domain, you can do that too. We offer you that. We have that list of accepted instruments on our Confluence. It's able to be filtered down by domain. We also publish downloadable spreadsheets of every single LOINC encoded instrument that we assess by domain on our value sets page. And just a note, when it comes to USDI and ECQM measures, whether it be NCQA or CMS, that's a lot of acronyms. The LOINC encoding, that terminology that is underwriting and underpinning those questions and answers is the key. Next slide. An example, this is where you can find every instrument we've ever looked at. Every instrument we've ever touched is here on the Gravity Accepted Social Risk Screening Assessment Instruments with a table. Any accepted instrument for any assessed domain is there. You can see the second column is the instrument name itself. The third column are the domains of which it's been accepted for reference. And there's a set of X's determining where it is within the LOINC encoding process. So if I wanted to just review all of the possible options out there, see if they were proprietary and can be used for my purpose, I can use the Gravity Accepted Social Risk Screening Assessment Instrument as a guide, right? No need to start brand new on your own if you don't have to. These have already been built and accepted for you. And if you utilize them, you're in alignment with some core guidance. Next slide. I mentioned also that in addition to that, which is the name of the instrument, to support all of you on our value sets page, our terminology team also has tables with the hyperlink of the instrument, the actual phrasing of the question, and the hyperlinks to that the answer list panel. Right. So this is another way to figure out what instrument you might use. You can see, as I mentioned, that core Hunger Vital Sign question is everywhere, right? The Hunger Vital Sign is used in almost every single comprehensive instrument. So you can see it's repeated over and over and over again. So if I were trying to figure out how to go forward with screening instruments, the summary statement is I can start with if my instrument comprehensive instrument is already accepted, I just encode it and I'm off to the races. If my instrument's not encoded, I can review what instruments were accepted in Gravity Confluence page. If I want to select instruments, it's best to do it by domain, and Gravity has a host of materials to support you in that. Again, these are already encoded, already accepted, already aligned with standards by design. Next slide. All right, so that was the section on instruments, which is actually the most straightforward one. When we hear about implementation barriers, it's really the pain of moving from a non-accepted instrument to a standardized instrument, or not understanding how to link encode. Something that came up in Tracy and our preparation for this meeting, though, is that Gravity continues to review instruments. So if you have an instrument that you're using in your ecosystem and you want to know if it meets criteria, we still, on a rolling basis, accept instruments. They have to be nationally disseminated for us to lead the link encoding, but we can assess whether or not they're aligned and can help you understand where it is in the pipeline if you send us an email. That's part of our ongoing role as the stewards of those value sets of reference. I'm now going to move into tips and tricks for implementing gravity-aligned diagnostic terms, which is those SNOMED CT terms and the ICD-10-CM concepts. The most important grounding, because diagnostic process is a professional process driven by many different types of professions, whether it be a registered dietitian, a social worker, a nurse practitioner, or some other like physician entity. It's really best supported by offering clinician-focused clinical decision tools, right? Gravity is very careful to say any active diagnosis needs to be patient-centered. You'll see that throughout our guidance. But the best thing we can do to support you all is show you how we have built diagnostic concepts in by design in Gravity and how they can align with the use of existing standardized screening questions, right? So our approach to this to lean in, and again, to support our friends at CMMI and CMS and the vast ecosystem that references the Accountable Health Community, its health-related social needs screening tool, was last year to start with working on this instrument, showing how Gravity diagnostic terminology can easily be elicited through application of the instrument, and then developing basically clinical decision support. Next slide. We want to note that it provides our best suggestions for IC10-CM and SNOMED CT codes that can issue directly, again, from those core domains of the AHC HRSN screening tool questions. We focused on the core questions, the core set, and not the optional ones. And the cool thing about it, again, I am a terminology nerd, so when I say it's cool, it might be a biased statement, is it provides a really deep view on the subtleties of the different diagnostic concepts that can come in through deeper conversation. Because some of the questions are pretty high level. You can't get into the subdimensions of each different domain that we know matter. And those subdimensions are very connected to different interventions. So the AHC HRSN resource provides a really good view on all of that, right? The high level concepts and the more granular concepts. We did talk about this resource in a prior Affinity meeting, so there's some pretty good references on it in the resource library. Not going to go too far into it today. The resource itself is in the resource library. You can see Demery is linked there in the chat. It's a really great place to start, and I'll show you why more in a couple slides. Next slide. Again, we talk about, I mentioned this earlier, I'm going to say it again. So we're very careful, even as we build resources to support clinical decision-making and diagnosis, to note that any social risk and social need documentation that is a diagnosis must be verified by a care team member by a personal interaction with the individual being screened or assessed. We do not recommend auto-encoding. We love the fact that our standardized instruments and things such as structure maps can suggest good diagnostic concepts. That's great. It's fantastic. We do need to have those concepts and those diagnoses confirmed with patients in the room in a patient-centered process, again, aligned with our data principles. This is partly because we recognize the risk inherent in the documentation of social risk. We've been talking about that extensively in our terminology public calls recently, and so in line with our data principles, we just say that from the outset. Next slide. So I'm just going to show again a brief, because the resources in the resource library, this is the tips and tricks. We focused on this resource in specific and other implementation affinity meetings. And so all of that can be found in the Confluence. But for anyone who has not seen any of those presentations or has not looked at the resource specifically, this is an example of what I was talking about, right? So if you look at the AAC HRSN question, what is your living situation today? There is that high level concept. When we answer concept, I do not have a steady place, and there's all these different subdimensions because it's not parsed out. If I were to have a suggested concept just from that answer, I would get an unspecified homelessness concept, right? But when we think about it more in detail, we start to pull apart the subcomponents, you can get these critical subdimensions of homelessness that matter for discharge planning, matter for home health, matter for, care coordination, right? Sheltered versus unsheltered homelessness. We built those concepts early in 2020, leaning into that. So if you piece apart the question, you can get these answers. So in some sense, as we'll talk about later, this resource is not just an example of how to apply the HCHRSN resource, it's also an example of how to use guided patient-centered interviewing to come up with really specific documentation with a patient of reference. Again, you can see the IC10-CM concept and the SNOMED CT concept both. Next slide. Again, the resource is on the Confluence. It's in the chat. There are tons of more examples in our Affinity meetings of talking about the resource. So I'm not going to go too far into it so we can get to other concepts and tips and tricks in Tracy's presentation, but know that that is there to support you. And look into the resource. If you're using a different tool, if you're using the Hunger Vital Sign, the same suggestions apply again, because the Hunger Vital Sign of the HCHRSN is the Hunger Vital Sign in the AFP Everyone tool. It's the Hunger Vital Sign in the Health Lead Screening tool. The Hunger Vital Sign is everywhere. So the guidance we have for that, for those questions here applies. And again, that same Norwalk or Nehruziman question for inadequate housing is on those same tools as well. So this is why this is a really great resource for us to lean into, because it is the logic is borrowed across so many others. We really want you to imagine this as a desk reference for clinical decision support for guided interviewing and clarified documentation. We really want to make sure we support you looking to your social care experts on your team for assistance and always ensuring the patient-centered in documentation. One thing of note, because I did not mention it here, but I've mentioned other presentations, when we think about the entities on a care team providing documentation in clinical spaces with IC10-CM, it's really important to reference the American Hospital Association 2019 guidance, which says because of the breadth of social risks and the diversity of care teams, any individual on a care team can document ICD-10-CM in collaboration with a clinical partner. So those community health workers, social workers, nurses, care managers, those entities who are directly talking with patients about addressing social needs and navigating to services, they are well positioned to support you in documenting with ICD-10-CM according to the AHA ruling. That ruling is also on the Confluence. Again, we're an evidence-based group, so pretty much every resource you could possibly imagine is in our resources for implementation. Next slide. All right, so this is the last section before we segue into a little bit of time for questions and answers and then into Tracy's presentation. This is, again, we're going to try to make sure that Tracy has time. So this is tips for implementing gravity-aligned intervention terms. Next slide. So our consensus intervention, we build consensus intervention terms for each social risk domain of reference. Our primary terminology for interventions is SNOMED CT, and it supports the gravity intervention framework, but we also curate social risk relevant concepts in HCPCS and CPT in our value sets. Examples are the new Medicare community health integration concepts that we have in our value sets as of June, the June update. Next slide. It's a nice arrow. You can find guidance on implementing those concepts again on the Confluence. Of note, the diagnostic guidance that we were just talking about is used to support those concepts because according to the Medicare Learning Network, documentation of the clinical need and the problem list is a really core element of social needs and CHI services. I think it was our March Affinity meeting that dived deep into these concepts, and that's also available on the Confluence. Next slide. The majority of gravity social risk specific terminologies in STEM and CT. Next slide. So this is our intervention framework. Again, it's built from a patient-centered perspective, built considering the multiple people on care teams who are assisting entities and patients in care, built to support the labor of social care, including the labor of evaluation of eligibility and assistance and coordination and navigation. Think of all of those roles that community health workers and care navigators and social workers are playing in your care teams. And so all of that language supports that, right? Both provision of services and the active coordination and navigation and eligibility and enrollment. We also align with the NASM activities of social care report that came out a little bit ago, that clinical element of adjusting a clinical care plan to accommodate social risk. Next slide. All of those are available on the Confluence for reference. So when we build SNOMED CT terms, we leverage the intervention framework and wrap the intervention types around key social risk domain programs and roles, such as SNAP, right? Refer to SNAP, education about SNAP, evaluation of eligibility for SNAP, and assistance with application for SNAP, right? So if I were trying to figure out what my team, like how to support my team in evaluation, these concepts can be utilized. That maybe is a little bit more sophisticated than you're ready for, but these all are all there to assist. Next slide. We also author coordination terms for social risk, including general social risk coordination terms, coordination of care plan, care team, and resources to address social needs. Next slide. And we also offer specific social risk coordination terms. So if I'm trying to specifically understand whether my team did a coordination plan to address food insecurity, there's terminology to support that. Same thing with transportation insecurity. Again, trying to capture that labor that's happening as we work to connect entities to social care programs. Next slide. This is the logic of how we build these concepts. So we have general coordination concepts, domain-specific coordination concepts, like I just mentioned, and then all of those specific program concepts. That is a lot of concepts. So we're going to go in the next slides about how to drill it down, but all of that terminology exists both for general coordination for social risks, specific coordination for an individual social risk, and then wrapping around every single social risk and core national program. Next slide. And so when I'm thinking about, what we've heard from implementers, we're going to hear with Tracy is you start with what's most important to your setting. Like, where do I start? How do I boil the ocean? And Tracy's going to speak to this in just about 5 minutes. What are the top referrals I make? Like, what processes have I standardized? What do you always do? And have you implemented community health integration concepts? Those are the top 3 things we've heard. Next slide. So in most settings, if I'm trying to support entities and aligning with regulatory drivers with intervention terms, you really can think about those core all social risk, all population helper referral terms: referral to social worker, referral to care manager, referral to community health worker, referral to charitable organization, referral to community resource network program, which includes that, but not limited to the 211s, the Find Helps, and the United States of the world, right? Most entities doing social care have automatic, always do this in response to a positive need processes that reference these concepts. So starting with these base simple concepts is a great initial step. Next slide. You also can implement referrals to common population-specific helper entities. Like if you refer every older individual at discharge to the area agency on aging, start there. Not every single concept, but if every population, every qualifying individual is referred to a AAA, refer them, right? We know our AAAs are ready and expert in social care integration and ready to receive that referral and do further assessment for patients, right? If you always refer to SNAP or WIC, build that, right? You also can do domain-specific referrals, like if you have an individual who is unhoused in an emergency room or discharge, and you always refer to coordinated entry, start there. Or every single unhoused individual is referred to emergency shelter at discharge from the ED, start there. Again, not every single concept. What do you always do? And starting there within all the breadth of value sets that you have, the terms and the value sets that you have. Next slide. And then once you have the referrals stabilized, the next thing to think about, again, referrals either to general helpers, referrals to population agencies, or referrals to programs for specific problems. The next thing to think about is trying to address common processes. Are there resources you always provide? Do you always provide gas vouchers to individuals who need them in order to access your care? Do you consistently try and assess individuals for eligibility for Meals on Wheels programs, right? Do you always ensure, and we call it the SNAP vaccine for a reason, that every single individual is assessed for eligibility in connection to SNAP who can be? It's so fundamental that sometimes written into statement like waiver plans, like it's always make sure that any individual is connected to SNAP that can be. So this is the next thing to lean into after you do the referral concepts. Next slide. All right, and then there's all the coordination you can build as well. For the sake of time, if it took a little bit longer than I anticipated, I'm going to move to the next slides. Next slide. I do not want to, oh, sorry, this is a repeat. Next slide. I do not want to neglect to miss Tracy's presentation. It's very important, and I think she has just about enough time to cover it. Summary statements are analyze what you almost always do and map that. Then keep things going, addressing layers of data to support deeper analysis, including outcomes, effectiveness, and sustainability. My apologies for going a little bit over, and then now I'm really honored to pass the mic to Tracy to carry us home.
Awesome. Thank you, Sarah. That was a great overview. So hi again, I'm Tracy Wayne, Digital Solutions Director at Elevance Health. It's my privilege to be here with you today and to give you a glimpse into our health plan's journey in collecting and standardizing SDOH data. Our work in this space began in 2018 when my clinical quality strategy team was charged with creating and executing an enterprise-wide SDOH strategy. But at that time, things were moving pretty slowly because there's really no tangible resources. SDOH was something that those of us who had passion did at the side of our desk to support. It really wasn't until about 2020 that the work accelerated because we have a steady funding stream. So we come a long way the past 6 years to get to where we are today, and I'm happy to share a little bit of that, what that looks like. So before launching into that discussion of what we did to standardize SDOH data, especially leveraging the Gravity Project resources, I wanted to provide some context for who we are. So Elevance Health is a lifetime trusted health partner whose purpose is to improve the health of humanity. We rebranded in June 2022 to signify our focus on elevating the importance of whole health and advancing health beyond healthcare for the communities that we serve. Our health plans operate in 33 markets, and that include 14 Blues license plans, 24 Medicaid plans, and 25 Medicare plans. So overall, we serve a lot, 113 million people through a diverse portfolio of medical, digital, pharmacy, behavioral, clinical, and complex care solutions. We employed about 103,000 associates globally, where 76,000 of them are in the US. And you may be familiar with our go-to-brand markets. It's go-to-market brands, which is Anthem Blue Cross Blue Shield, WellPoint, and Carelon, which means full and complete care. So next slide, please. So our company really is committed to advancing health equity. And that is the idea that everyone has a fair and just opportunity to be as healthy as possible. We recognize that to really address whole health and reduce disparities that we're seeing, we need centralized and actionable data. So when we look at factors that drive the health of our communities, we see that only 20% of those drivers are connected to clinical care, and that is your typical physical, behavioral, maternal health, inpatient, emergency, and pharmacy utilization. The other 80% of health is driven by what happens outside of the doctor's office, and that includes your socioeconomic, environmental, geographic, and behavioral factors. We really want to gain data-driven insights into that 80%. We believe looking at all of the factors together, it'll give us the ability to address more than medical needs in order to improve whole health and then to track population health over time. Next slide, please. So what we ended up doing is we add social data on top of our clinical data in our data foundation so that we can have a holistic view of our membership and the communities that they live in. We brought in on the left side first community social risk data, such as access to public transportation. That's going to be based on the latest information from reputable public sources like American Community Survey. And then on the right side, we ingested member social needs data, for example, food, housing, transportation needs. That is based on member and vendor sources that we glean from claims, health risk assessments, and social need screening. And then we summarize all of these public and member data in aggregate, and we also break them out by demographics such as age, gender, race, ethnicity, community type. And we looked at it by geography as well, globally, across the enterprise, each state, region, county, zip code, so that we can easily identify health disparities or inequities. So you might be curious, well, why should health plans care about social data now, if not before? Well, for our members, it really is the right thing to do. As payers, we recognize that we have an opportunity to evaluate health as a bigger whole picture, then collaborate in smart ways to improve it. And also, we're seeing an increased industry demand to address social needs. And first of all, it's NCQA. Starting last year, the health equity accreditation programs, both the base and the plus, um, and also HEDIS reporting, have very specific requirements surrounding social need data capture and then tracking the interventions. And then secondly, CMS. Starting this year, social needs screening is mandatory for Medicare enrollees, and we anticipate that intervention tracking will be following. And then thirdly, our Medicaid states, more and more of those agencies are asking health plans to screen for social needs, refer members to resources, and then close the gap. And then we also recognize that CMS and the Joint Commission have implemented similar social data requirements for the providers last year, which will help improve the social data capture flowing into the health plans. So how do we talk about all of these new data in the same way and then benchmark our progress over time? So the good news is CMS and NCQA, their data elements are very much aligned to Gravity. So I'm responsible internally to share information from the Gravity project with our associates across enterprise, so to make sure that we're staying on top of the changes that are evolving, as well as to provide feedback to Gravity project about what we need to implement. And then internally, we created a enterprise-wide data foundation that has supports whole health analytics, and we implement it with appropriate data governance controls in place for security and privacy, so that our associates can confidently access the data that they need. Next, please. So I just want to give a shout out to Gravity Project. I really appreciate what they're doing to standardize SDOH with this consensus-driven process. And then also especially that it supports ASTPONC's USDDI requirements. So the Gravity Project gave us a lot of insights into the SDOH priorities and stakeholder interests, as well as a chance to advocate for things that matter to our company. And I think that's just really a mutually beneficial collaboration. So since 2019, the Gravity Project has published data sets for about 20 social domains to date across the 4 activities that Sarah provided an overview on, which is over screening, diagnosis, goal setting, and interventions. So at Elevance Health, we prioritize 10 domains that are circled in red here as the minimum that we need for SDOH screening requirements and then to implement some sort of interventions. And that really is driven by the need to meet NCQA and CMS requirements. Those are happen to be food, housing, transportation, finance, safety, material hardship, and social connection. So you might wonder how do we arrive at these priorities? And Sarah mentioned earlier, it's really tempting to try to boil the ocean. So for us, we focus on the 20% that will bring the 80% of value to our organization. Next, please. I know this slide's kind of busy, but it does break down the 10 social priority domains, showing on the left side here which industry requirements are met. That is specifically NCQA Health Equity Accreditation Plus, and HEDIS reporting that relies on use of LOINC, and then also CMS as also relies on the use of LOINC. So we try to screen members for social needs using standardized assessment whenever possible. Organization our size with so many markets, we have about, more than 3,000 different types of social assessments that has social needs questions in there that we have to map to. So when we took a look internally to see, well, what standardized tools are we using? So on the right here, we have 3 most prevalent tools used by our different health plans, and that is your AHC, HRSN, prepare and also health needs. So we also map Z codes and non-standardized social assessment to the relevant social domains based on internal data governance recommendations. Because we recognize that having more data can help us inform social needs, but it may not be reportable to HEDIS or CMS because they're not using LOINC. During 2018 to 2020, when gravity value sets were not yet available or adopted by our organization, we created an internal taxonomy of what we call the member level attributes. And that at that time was based on guidance from the initial siren work as well as care management. We maintain this internal taxonomy to fill in the gap where standard value set is not available yet. But we also map our homegrown member attributes to Gravity project terminology wherever they are aligned. So in other words, we keep two taxonomies, but we're hoping in the near future we'll be able to just use one, which is the Gravity standard. But we recognize that there is a time where we just need to bring everyone along to align. Next slide, please. This is a very high level view of Elevance Health Social and Health Equity Data Foundation, which is a single source of truth for whole health management. The left side are data inputs that are aggregated from IT from places like claims, health records, social need assessments, purchase sources, and public data. The middle really is where disparate clinical, social, and demographics data are standardized and then fed into this centralized repository. The right side are consumers of the data across different business units for things like analytics and insights, NCQA accreditation, HEDIS data engine, care management operations, and social impact work. Our associates then act on the data-driven insights from the information to develop meaningful health outcome-oriented strategies to reduce health disparities among our population. Next, please. I want to touch a little bit about the role of data governance in driving standardization and how we bring everyone on the same page. So at Elevance Health, we set up 3 forums to talk about SDOH data. The first one on the left is a big learning collaborative with very broad representation of functional units across the enterprise. And we share information, onboard people, they can ask questions. This really allowed us to minimize some of the duplicative efforts in different teams and drives alignment across the board. The second in the middle is a select group of people. We discuss in depth the social data model, what type of secure access to grant to different associates. And then we also make decisions based on industry guidance like the Gravity project. The third on the right is an open office hour that supports our data users with questions they may have regarding SDOH data architecture and the different code sets. Whenever we have policies and procedures that are relevant to SDOH or health equity, we bring them to an enterprise data governance body and we vet it for implementation. Next, please. And so as I close out, I want to share with you just some key reflections of what we've learned. First of all, focus on mandates and table stakes. It's critical to design a data foundation, analytics, insights tools, and industry and interventions with industry standards in mind, because that's going to get us buy-in from senior leadership, which will come with dollar support and can also guide some of those data governance discussions. We try to bring everyone to the table to streamline the interests of the different stakeholders. And then again, that'll help minimize duplication and maximize investment. We work collaboratively with multifunctional teams to carry the work further and really leveraging the power of many to scale programs and impact. We implement a regular forum so we can share knowledge and onboard new staff. And we try to make the data meaningful and actionable and track interventions over time to demonstrate impact and outcomes. With that, next slide, I think that brings us to the end of the presentation, and I'm gonna at this time, I'm guessing, Sarah, we're opening the floor to questions and dialogue, and we can explore more about this topic. So turn it back to you, Sarah.
Yes, thank you so much. I was muted there for a second. I just want to note, we do not have as much time as I wanted for questions. We do feel free to raise your hand in these last few minutes. You also can find us, the terminology team, on any terminology call. You'll find us in future Affinity meetings, and Tracy also gave her information there. But if anyone has any questions, feel free to raise your hand. But before we go into that, I just want to note, it's so exciting, Tracy, to see the application of these concepts in real life toward the global goal of health equity and population health. I know this was Gravity was conceived in 2019, trying to enable that mission. And the fact that it's being used in real time like this is very, very powerful. So grateful for your leadership. Tracy's a very engaged member. She helps us make our work better on a regular basis. So very, very thankful. Looks like we might have some questions. Yeah, so Tim, so there's a question regarding location of data and health records on where it can be found. Does Gravity have recommendations on how to map the LOINC codes in various EHR systems? We use Cerner. Tim, it's true that Fenix offers all Fenix instruments that apply are included in Gravity as well, and the questions you can be crosswalked within our value sets. So Gravity is kind of the babble fish when it comes to Fenix and other instruments, those value set tables and resources that I mentioned. The reason why I stepped outside of just LOINC is because some of the information in social histories is not screening information. And so it's actually like diagnostic concepts or findings, such as some of the administrative data you can find in intake or documentations of homelessness. And so this is where these concepts actually are really critical. If a person's doing an intake assessment and assessing someone is homeless upon discharge, that information matters. It can be a SNOMED CT concept, even if it's not a LOINC concept. And so trying to analyze processes and where all the information is coming from is definitely a work in progress for any system. But this is where those codes can help, whether it's LOINC or SNOMED or ICD, if in the specific location, the specific flow sheet or chart area is not as important as the code behind it that can be the common theme.
And Sarah can chime in too,
Yeah.
from our experience. And so we recognize that not all EHRs have mapped the LOINC code to the standard question. So even though some of our EHR vendors, they have already implemented, let's say, the prepare tool or the HC tool. However, they're capturing the information as question and answer, like text. So that to us, it's not coded, it's not codified. So it's a little bit difficult to work with non-structured information. So the workaround for now is on the back end, we map like what we're getting from them to standardized code, but we also engage in discussion with the EHR vendor to show them what we need to get to a structured data format, and that conversation is ongoing. And so once they make the changes, it'll benefit everyone in the ecosystem.
Agreed, Tracy, agreed.
It's a process.
It is a work in progress. That's what I was going to say as well. All right, we are close to a time, and again, my apologies for taking up more of the presentation time. I'm really glad we got to highlight all of Tracy's questions. There was so much in this presentation, so many resources on the Confluence. These slides will be available for reference, including applying all of the brilliant pearls that Tracy and Elevance Health have applied in their processes, again, both at member-specific and all population health approaches. Next slide, because we do need to close out at 3:30 EST. I think there's another slide for closing. Maybe not. Our next meeting is the last Thursday in October, so we'll join us for our next Affinity meeting. Thank you so much. Sorry. Thank you. You can find, again, this recording is going to be in two places because a specific ask on terminology tips and tricks. It'll be in our webinar on specific resources and topics section. It'll also be in the calendar where we include every single recording of every Affinity meeting. You can find every single one of the resources that we mentioned and hyperlinked in the chat on the Gravity resources for implementation, including that analysis of existing instruments that we highlighted in presentation and in the recent conversation. Again, great crosswalk between Fenix and all the other instruments. We are so grateful for your time and very grateful for our friend and member and supporter, Tracy Wang. We will see you in a few weeks in this Affinity meeting, and maybe I'll see you at 4 o'clock Eastern Standard Time for the Terminology Public Call. Thank you so much. Thanks for
Thank
joining.
you. Bye.